Okay. Good morning, Dr. Chun, Dr. Mikhaylov, and good early morning, actually, early morning, and also good morning, Professor Ayan, and good afternoon, Dr. Long.
Everybody.
Hello, everyone. I'm Dr. Chenyang Jiang from Seoul Rongshao Hospital, affiliated to Zhejiang University School of Medicine. This time, we are going to have an online seminar on nanosecond PFA for PFA. This is a completely new. It's a second generation or third generation of PFA modality. I think we are going to have 3 live case demo, and in this session, we will have a good discussion, and we will enjoy the conversation, and we discuss the future and the current problems, everything, and by our experts. And this platform also is open to internationally, especially to our Chinese colleagues. And this session is one part of Ayan International AF Forum, which will be held Saturday after tomorrow. So let's begin. Our friends, let me introduce my colleagues. One is Professor Zhen from West China Hospital, and the second one is from the first affiliated hospital of Hospital University of Science Technology of China, Professor Shu Hao. Shu Hao is president of Anhui Province, and again, Wu Kai, Professor Wu Kai. Yeah, 3 of us will co-host together with our distinguished international experts of this session. And so let's begin. So first, yeah.
Good morning, Dr. Reddy.
Hello. Sorry to join late.
Oh yeah. So good morning, Dr. Reddy.
Morning. How are you?
I'm great. Just now I introduced. I opened this session. Thank you for your joining in this session in very early morning in the States. I think I understand this is very difficult for you, and it's very nice. It's great for us for your joining participation, and also we have. Let me introduce again experts from Frankfurt, Professor Julian Chun, and distinguished experts from National Coordination Center of Emergency Medicine, Kazakhstan, Professor Ayan, and also Professor Vinh Hong Long from Vietnam National Heart International Institute, Vietnam, and also Professor Mikhaylov from Almazov National Medical Research Center, Russia, and also we have 3 Chinese colleagues: Professor Shen Wenzhi from Nanjing Zhuang Tower Hospital, Nanjing University Medical School, and Professor Ling Shen from Affiliated Hospital of Nantong University, and Professor Chen Long from Zhongda Hospital, Southeast University of China. And hello, everyone. So let's begin our session, great session. And also, please, let me welcome the first presenter, Professor Ling Tianrou from Ruijin Hospital, Shanghai Jiao Tong University School of Medicine. This is introduction of Professor Ling Tianrou, and she is associated chief physician of cardiology, co-operator of the electrophysiology team, and also other many titles. And Professor Ling, please.
Okay, thank you for your introduction, Professor Jiang. Can you hear me?
Yes, please go ahead.
Okay. I'll show you a case of PFA with nanoseconds. I will introduce the case in Chinese. I think there will be a translator help to help us.
Now moving on, I'm going to introduce to everyone about this case situation. This is a recent case carried out by Nanosecond PFA. This is a atrial fibrillation ablation case. It's my great honor to present this case to you. First, this is an 82 senior female patient. This patient has suffered more than 10-year paroxysmal palpitation. We already checked about the patient ECG, and then after ECG diagnosis, we confirm this patient is paroxysmal atrial fibrillation, PAF. And then we check about the patient coronary angiogram, CAG. This look quite good. Patient suffer from plaques, but it doesn't affect the patient's situation. The plaque doesn't affect the patients. At the same time, myocardial breach has been observed for the patient's coronary artery. Now the patient needs to orally administer those anticoagulation drug. The patient also suffered the severe myocardial breach diagnosis. That stenosis can reach 90%. So that's why when the patient suffered from the AF, he always presented those severe symptoms. So that's why the patient get high intention to go through surgery. And then the patient had come to our hospital after admitted. The patient mentioned that he want to go through those AF ablation. This slide is about the patient's history. We already covered the major part in my previous introduction. So 82 senior female patient, and also PAF suffer from myocardial breach. So since this is a paroxysmal AF, this is patient sinus rhythm. You can see this rhythm is quite normal. This is patient echocardiography. Now you can check about the LA, left atrial endoscopy. Although the diameter for LA is 39 millimeter, especially this is a Chinese elder female patients, 39 millimeter is quite normal. But consider all the different situations, we believe 39 millimeter is quite approaching the top ceiling. Because if this is an elder senior citizen and it's quite slim rather than fat, we believe this LA and anterior posterior diameter is not 39. Normally it's 35 millimeter at most. Here for the EF, ejection fraction value is quite normal, 66%. At the same time, patient also accompanied by mild aortic valve regurgitation. No more specific symptom that should come to your attention. Before surgery, this patient also complete the CTA for the left atrium. First, we want to see whether the patient suffer from potential thrombosis. At the same time, we want to get a complete left atrium image. This is more like a basic routine for the patient before they go through the AF ablation. You can see this is CTA combined image. So generally speaking, the left atrium is well filled with a contrast agent. No obvious filling defect has been observed. Besides, at the same time, bilateral pulmonary vein also presented a normal course. No obvious filling defect is seen. Because this time we adopted the Nanosecond PFA. This is also the very first time for us to try this technology. So that's why we prefer to start with a stable patient with also better surgery favor condition. This time, the Nanosecond PFA equipment is offered by the PulseCare from Shenzhen. So you can see we have used a pulse electrical field ablation catheter for the treatment. We have done several ablations, such as 12 ablation for LSPV, 12 for the LIPV, 4 between the two left side pulmonary veins, and also 12 for the RSPV, 18 for the RIPV, and 6 between the two right side pulmonary vein, and 6 for the SVC. Generally speaking, this ablation record is in line with ablation protocol. In total, we have carried forward the 70 ablation, with ablation time of the 26 minutes Remax. Now you can see for the electrical isolation of the pulmonary vein and the superior vena cava was quite successful. The patient already have sinus rhythm after operation. We also check about the patient conditions. During the very next day work round, we notice the patient already been quite well after surgery. Now let's check about the ECG before ablation. So before the ablation, it's a sinus rhythm. Consider the patient's senior age. We want to make sure the patient's hemodynamics will be stable. And then we decided the patient need to go through surgery. Now I would like to pass the floor to our staff. Ask the staff to play the surgery video for me, please. Hi, can you hear me? Hi, Professor Ling, I can hear you. Give me 1 second to play the video. No problem, wait a minute. So please make sure you can see my screen, and then I'm going to share my screen. And besides, Professor, if you need me to fast forward to a later stage of the surgery, just let me know. Okay, so based on your instruction, it seems like I cannot pull forward or pull back the video. It is you who control it, right? Yes, exactly. Okay, so what you see is actually a real surgery video. So in the very left of this video, you can see Professor Wu Liqun from our hospital. Professor Wu Liqun is a main and major operator for the surgery. Myself is a surgery first assistant. You can also see another staff within the frame. By the way, this surgery is quite special in its own kind. We choose a surgery in Jiangsu, Ruijin City People's Hospital. That's why you can see the chief of the cardiology department of the Ruijin People's Hospital also participate in the same surgery. Right now, Professor Wu already complete bilateral femoral vein puncture. Usually, we're going to place the decapular CS coronary sinus catheter. This will give us a better intracardiac electrocardiogram. This will be connected with a surface electrocardiogram. At the same time, we also work together with Abbott 3D mapping equipment. Now you can see we are performing in interatrial septal puncture. You can see in AP, anterior posterior, we use standard method. So in the AP, anterior posterior, we are pulling through and pulling down the puncture needle. Right now, the sheath is still on. Now you can see in the LAO view, left anterior oblique view, we are performing the puncture. We do understand some experts prefer the RAO, right anterior oblique view, to carry out their puncture. However, from our perspective, we prefer LAO over the RAO. Because if you are going to performing the puncture from LAO, you can see clearly how deep this puncture needle has reached. Now you can feel the loss of resistance from the sheaths, and now the needle has officially entered into the left atrium. So do one aspiration. You can see some blood from the aspiration. These are atrial blood, arterial blood. It seems like Professor Wu wants to have the puncture in the lower part, so now you can see Madam Wu is actually adjusting the needle. Well, actually, one question, Professor Ling, I would like to know for this patient, is the patient goes through general anesthesia or the local anesthesia? Well, actually, this patient, we prefer general anesthesia. Okay, further up questions, general anesthesia with intubation? Yes, we confirm it's a general anesthesia with intubation. It seems like all those general anesthesia situation, I think anesthesia is always performed with intubation. I also want to visit Professor Chu's EP lab. I know that they do deep sedations from the respiratory system. Prefer to do it through the respiratory tract. However, our department of the anesthesiology don't really like this method and want to do their own way. They believe if the procedure duration of the operation time is at least half an hour, they believe the most safe way to perform the surgery is actually general anesthesia with oral intubation. I believe we can also propose this topic for the later discussion, because nanosecond also get their own advantage, because the patient only suffer from limited pain. But of course, we can try local anesthesia with other patient. I know that right now for our center, the PFA is more like go with the general anesthesia. But if it's other PFA with a microsecond, they see that local anesthesia only give patients certain comfort and still suffer certain pain and discomfort. They say the adequate deep sedation may not change patient's pain. So perhaps after surgery, patient may not remember whether they are pain or not during the surgery, but at least during the surgery, you can observe the patient is super discomfort. Besides, on top of the pain, during surgery, patient may suffer from convulsion or seizure. And then we decided for the microsecond and other PFA, the most proper way is to general anesthesia. But at least for this patient we are performing, for everyone, we adopted general anesthesia. But of course, if the future patients is more like a young population, youngsters, of course, you can try local anesthesia. In spite of the general anesthesia for this patient. And we also try to monitor carefully for patient twitching and also myoclonus. Later, if time allowed, I can share with you with greater detail for this patient twitching situation. Now you can see the interatrial septal puncture has been completed. Now you can see the guide wire has entered the left atrium. Yes, you can see it. It seemed like it dropped off, right? Yes, drop off. But don't worry, the subsequent surgery is quite smooth. We don't have the second punctures, we just continue. This is also very first time for us to try their system. Yes, very first time to use the PulseCare. Hi, we don't mind to fast forward. We would like to check about the surgery outcome.
The answer is no. If you use the generations, the prognosis is no. So really, I just want to ask you this question. So what's the benefit, do you think, is a nanosecond posterior ablation compared with the microsecond? Because I know you,
Well,
you
yeah.
already tried many times.
Yeah, so I think that's one of the very interesting aspects of this technology. So the nanosecond technologies I've used in the past, which is not this one, but other nanosecond
Pulse
technologies.
bioscience, I know. Yeah, pulse bioscience.
Yeah, so the advantage there is by going nanosecond, they're able to increase the pulse amplitude and basically create a denser electrical field without causing too much local heating. But my understanding is that this technology is a little bit different. As you know, it's been published already, that it's nanosecond, but the voltage amplitude is still, and please correct me, but my understanding is it's only around 2000 volts, which is, for nanosecond, 2000 volts is let's say on the lower side, because
It's
again,
very low. Yeah.
for pulse, it's 10,000 plus volts. So that's why I think it's very interesting. And my understanding is this allows better tolerance in terms of sedation, anesthesia. So it's a little bit different than what I'm used to. So here, I think the idea is nanosecond mainly to allow patient tolerance. And so, of course, then the question I have in my mind is how good is the electrical field to create ablation? I know it's been published and it seems like it's still quite good. So that's why I'm very interested to see.
Yeah,
Yeah,
it's not
maybe.
at least not bad. From my on my experience, we have done more than 30 cases, and the result not so bad, and
Yeah.
almost not inferior to millisecond, microsecond.
I also just wanted to add on this while we are watching the transeptal is I noticed in the introduction that there were also 12 applications per vein, if I understood correctly. And this is maybe in line what Vivek just commented, that in order to maintain this durable lesion, apparently a couple of more shots are required. So, and this is also based on your experience. Do you just shoot at one position and taking advantage of the 3D mapping, or how do you, let's say, tailor the anatomic locations of each of those applications? Any specific recipe on this?
Actually, I don't know there, just use the general anesthesia.
My question was, or maybe you will comment later during the case, if you start, for instance, a little deeper inside of the PV with the first 2 or 3 or 4 shots, and then come from a more distal towards a more proximal position, or do you just deploy the 12 shots at any site, or if there's any, let's say, systematic approach on this?
So like a basket and flower, and it's a one-shot modality, and ablate initially the vein first, and then there's the antrum. I don't know. Usually two for one side, one side, and then rotate, and application 2 more. Then it's done, and then to change the type from basket to the flower, and ablate the antrum.
It's a little similar to the Boston's PFA.
Yeah, very similar.
Yeah, the whole protocol.
Okay.
Yeah, we will show you the catheter.
Yeah. So Professor Ling, so you use Abbott inside the system, 3D mapping system.
Yes, of course.
Yes, we do. I'm at the airport. The signal is not very good.
I see. Actually, we can you know move forward. Just
快近点，快近点。
Yeah.
直接到那个导管进去吧。
Yes, like this. Yeah.
Very similar, like a spare pulse. Very similar to spare pulse.
Similar.
Very similar.
Yes, very similar.
The PFA parameter is a little different for them. Once you click the button, it's 10 times series, 10 times shock for one series, longer than other, longer than the microseconds PFA. Yeah, first at the earth of the PV.
So, by the way, I have a question for Professor Ling. What's the ACT before you beginning ablation?
Usually we use ACT a little lower, like 250
seconds.
Yeah.
That's interesting. The ACT of 250 is a little bit lower than what we're used to. Is there a reason, or is that normal for your PFA cases? Meaning, are you
Usually more
using
than
a lower
300.
ACT?
Well, usually more than 300, I think.
Yeah, for me, I
yes,
will
we use the same
achieve
tool
350.
as we do ablation before.
Can you just briefly comment for us on the size of the sheath?
Size of sheath is 12. Yeah, it's 12 French.
Another workflow question. You started, if I got it and saw it correctly, at the left upper vein, and then you move on now to the left lower vein, or is it or what is your typical sequence? Because there's one paper, I guess, from Brussels, which did indicate that the GP response and the bradycardia events was diminished if it was started at the right upper pulmonary vein. This was speaking for, of course, not nanosecond ablation, but do you see any differences with that Brady events or vagal responses? Let's put it this way.
We also noticed such paper, but we think the GP problem is not trouble. It doesn't trouble us a lot. Before we start the procedure, we will give atropine, 1 milligram. So we do as easy as we want to do as anatomic. So usually we will do LSPV first, then L inferior PV. But sometimes we will just if it's more easier to enter ISPV, we will do ISPV ablation after LSPV, but not a routine. So what do you think? You think you like to, after LSPV ablation, you like to do ISPV ablation? Or which one?
Yeah. In our experience, we could not basically reproduce the mitigating effect of starting with a right upper vein first and then observing lower rates. Of course, I think it is a good idea to consider atropine. However, in a subgroup of older male patients with known prostate problem, we are a little, let's say, more conservative on giving high doses of atropine, and therefore we are prepared to pace in case of need. But my point is, we did not observe, maybe Vivek, you have a different experience on this too, but we did not observe a difference if we started ablating on the right upper first.
Yeah, I mean, we have not done it systematically enough. I don't think I can comment. We do tend to do the left veins first anyway. So I don't think I can comment on that. I'm sorry, I was just watching this. So the applications, it seems like a series of pulses over like 2 or 3 seconds each. Is that right? Can you just explain those are all applications, right? So what is your strategy here? I can see that your basket, you deliver 2 pulses, and then are you rotating, or what is happening here exactly?
Actually, as a standard protocol, we need to rotate the catheter 3 times in each vein. And each time, when after, I remember, after 3 times, after 3 times, I 3 times shock for once ablation, then rotate. They different than other catheters. They ask us to rotate 3 times in 1 PV.
And it's 2 applications per location. So your 2 applications rotate 2, rotate 2.
Yes, yes. 2 rotate, then again 2, and then yes, 6 times.
Yeah, they also suggest us to do ablation between the PVs, so we also do that.
Mm.
And then in the time in between applications,
There is no clear requirement for the time between the applications.
yeah, it seems fairly quick between applications, right?
Yes.
Yeah, about 2 or 3 seconds between. Okay. So I see.
So where do you exactly deliver your applications? Where you see the signals, you try to abolish them, or what? Or you just go all around first?
First we see the signals, PV signals, we will do the ablation, but for PFA, the signal doesn't mean everything because after one shock, the signal just gone. So even if there is no signal, we will also finish the whole protocol as requirement.
Okay, so as we see now, you try to pace from the vein, and there's some conduction to the left atrium. Is that right?
No, we are not pacing. Just now, it's ablation. The signals are ablation, but at last we paced to see if there are flutter or other special arrhythmia. We can do ablation. We routinely do that, but now we just map the SVC and want to isolate SVC. Because we find PFA is quite safe and easy to do SVC ablation. And it's also a frequent trigger in Asian population.
Now you can see that we'll move on to the isolation for the upper part.
Yes.
So we'll move on to the parasiva. Hi, Madam Ling. We noticed the next operator, the author Kang. Can I hear you clearly? Would you mind to mention one more time? We noticed Professor Singh also online, so everyone is ready. Okay, got it. Okay, so how about this? Let me wrap up. I think we already finished it. Now you can see we not only cover the parasiva isolation, we finish it all. Thank you so much. Thank you.